So I think our role here is just to facilitate some reporting out from the concurrent strategy sessions. And so we're going to ask someone from each of those sessions to give us up to 2 minutes or so, kind of the key points, summarize some of the issues addressed, and hopefully some solutions to those issues.
Great. So why don't we just go down the list with the building capacity in smaller systems that M. Chung was leading over there. I guess, M, you'd be the first person that we would look to, but you might delegate this to someone else for a summary of what you've learned.
I think M had to take off.
I'm standing in for M. She had to leave. So hopefully I get this right since I wasn't there the whole time. But the issue of building capacity in small networks and low resource settings, an example that sort of just frames the discussion is for instance, in LA Care population, the LA Care population, most of them are receiving care in mom and pop shops. And so reaching those mom and pop shops can be difficult. And so thinking about the visibility of those types of organizations to researchers and how we can find and connect that to them, it's really on us to go to them and find their networks, maybe not just go to Academy Health every year, but think about the types of meetings or types of organizing that they're already doing and to leverage that. They also have the advantage of being nimble often, these smaller organizations, so it's not always just a downside to work with them. They often have the capacity to serve special or hard to reach populations. So if you have a certain research interest that's narrow, they might actually be the best people to work with to serve that group. There is the issue of adapting evidence to their settings, since often the work that we've done has been in larger systems. We have to be mindful that sometimes the solutions that we think are evidence-based may not actually be evidence-based in their setting. We also have to be mindful to give back so that we're not being exploitative or overly burdensome, given that these are often small and that they don't have a ton of resources. We need to think about ways that we are especially mindful of giving back. So partnering to leverage for external support, for instance, as researchers, we actually do have the skills in grant writing, so helping them with grant writing for maybe even things not quite related to your project, but that will build goodwill. Demonstrating cost effectiveness or program benefits, even if it's not an RCT, they can then take that evidence, and if we prepackage it in a way that's sellable for them to then go out and get their own funding, even if we're not helping them with the grant writing themselves. And an example there was somebody had worked with DHHS and helped show there was cost effectiveness of preventive care. And that was really extremely useful to their partners to then turn around and say, hey, you know, like I need to be able to do this and get their own funding. Also, there's the issue of sustainability and lasting change. So small organizations, turnover can be much more traumatic to them. Also, if you put in one FTE of a person and then you pull them out at the end of the program, that's going to change their dynamic a lot more dramatically than maybe in a larger organization. So thinking about, you know, without having a policy change or fiscal mandate, what supports that sustainability? And somebody suggested consumer groups could actually help if they're involved in supporting the demand for that change to stay in place, and so that you don't necessarily have to just be pushing the change, but rather be pulling the sustainability out from the consumers on their advocacy side.
Wonderful, thank you.
I got everything.
Great. Maybe we'll just give a moment to ask any questions or offer any thoughts on doing this type of work with smaller organizations and under-resourced organizations. And if not, we will skip to the second group.
Go out of order slightly and go to the third group before the second. So Jackie Fickle and I will do tag team. So I get a minute and you get a minute. We talked about strategies for engaged, partnership-oriented, in some cases embedded research. within healthcare organizations. And I contributed experiences and insights from colleagues within VA and Kaiser, where we've had a fair amount of experience in trying to work with our policy and practice leaders and what we've learned. Others in the session offered their own advice. I won't give any of the answers, but suffice it to say that there is a fair amount of guidance that is evolving and emerging from all of those experiences, and how you navigate and negotiate a set of research activities that attempt to simultaneously meet the needs and the priorities of health system leaders and clinicians and policymakers, other decision makers, and are of interest to the research community and are of value in terms of generating scientific generalizable knowledge. So that's what this meeting is all about. Again, within this room, there's a fair amount of experience, an activity that many of us feel is really the ultimate of the sort of research that we can be conducting with immediate benefits and positive feedback. And I would just encourage those who haven't yet dipped a toe to turn to your counterparts who have been there for advice and guidance.
And that pretty much covered it, but amongst the discussion from people that were from various different large and small organizations, we really touched on the multiple levels of the organization, the things you got to consider within these partnerships, multiple levels of the organization, not just having one champion, but a variety of people that you partner with. Using things like the PCORI guidelines to engage with the stakeholders, the processes as well as the data, just all the various things, lots of complex things to think about.
Great. Any comments or questions?
Michael?
Yeah, I actually want to go back to the first group, although you guys are free to chime in as well. I'm wondering if there are actually, and if this came up during your discussion, if there are advantages to working in, smaller health systems. I think, larger hospitals and systems have obvious advantages in terms of economies of scale, but sometimes the organizational structure is so complex and the scope is so large that it's really hard to do things on that big scale. And I don't know any organization that is adequately resourced. So I think we're all coming at it from a position of being under-resourced.
Yeah, so two specific things that were raised. One was sort of the more nimble nature. So if you've got a person and they agree that what you're doing is important, and then you kind of have the green light and you don't necessarily have to go to all the layers of approvals and sort of like, well, we need to take this to some committee or something like that, and that can be powerful. Also, the idea of serving special populations. So a lot of times smaller organizations have a more focused mission themselves, and so if that's concordant with the work you're doing, that can be really helpful because, they're not going to pivot and decide that in a couple months, actually, this quarter we're focusing on a different population and your research is no longer of interest, because they'll still be sticking with the same messages.
Okay.
Great. Okay, so next we'll hear from Maura about professional development in healthcare systems.
Great, thanks. So we talked about the ability of clinicians or other people within health systems having the bandwidth to be able to engage in the kind of work that we talked about today. So one topic we discussed was the idea of the time set aside, and if people sometimes get time set aside for research, could they do the same for a quality improvement, or could quality improvement research be done together, married together, and then practiced together so that people get that time set aside. But trying to figure out how people can have time, particularly I think people who are, so there are people who are professionally researchers, and then there are people who need to be engaged in the work, who are maybe clinicians who spend most of their time doing clinical time, but don't have time to set aside to sort of think and reflect and look at data and being engaged, fully engaged. And so trying to think about solutions for that was one topic we discussed. We also discussed the idea of people getting some kind of bonus, which doesn't have to be a money bonus, but like an additional time bonus for getting good results out of their improvement or innovation or implementation science research. We asked who did this well, and some possible areas were Kaiser VA, UCSF in terms of this. So we talked about learning more about who's doing it well to figure out if others could emulate parts of that. We discussed changes to medical education, getting to people early, talking about improvement, team care, those kinds of things early on. We also discussed the use of data, that there's been so much work with health systems, with EHRs, also on the CTSA side in terms of developing different data capabilities, that if we could increase appreciation of data generally, that would be useful. Increase the availability, interpretation, and just general use of data for these purposes would be an enormous improvement. We also discussed that there are a number of courses, such as those offered by Cincinnati Children's, by Intermountain, other places where you can get sort of research and improvement or implementation science, those kinds of things. USC has some, QI, UCLA has some, and the idea of could we look regionally at, instead of, or in addition to folks using those programs, is there something we could develop regionally that would be a bit more consistent and meet the needs locally? What would that look like, and who might come around the table to brainstorm about whether something like that could be possible?
Great. Any thoughts or comments? And if not, we will move on to Tony Kuo and building capacity in systems outside of healthcare.
Standing in for Tony.
And standing in for Tony. Sorry, I'm back. So the list that Tony gave me, the topics, I think one topic was the use of iterative cycles of learning, using plan, do, study, act cycles, iterative learning cycles for helping with implementation outside of healthcare, outside of places where that is not the typical way that the change happens. So promoting that as a core method of learning, using kind of the scientific method at that level to support change. The second area that was discussed was having an open forum to actually publish and share negative results, to talk about the messiness of doing research and what hasn't worked. And as long as the work was done well and it didn't produce results, that would be good to share. There was a discussion of whether we could have maybe a journal of failed practice. I'm not sure if our CTSAs would want to sponsor such a journal, but perhaps we could do that in some kind of forum. A third point was so helping to promote novel or just different approaches to learning and inquiry in community research, public health, other kinds of systems that come from other sectors or disciplines, which is done a lot in healthcare but hasn't necessarily made it out to others. So examples of how engineers look at problems, some of the system sciences that are used for things like traffic safety but are not necessarily used in population health or public health practice. So I think those are the three major points.
Any comments on that one? All right. So innovations in academic training, Luis Gomez.
So we agreed that something about implementation science and quality improvement represent the sort of the big buckets that would describe the kind of innovative academic training that is necessary. And then we proceeded to talk about, well, what is it about those that need to happen more broadly, and what do we need to understand about those? And I think a couple of the big ideas are that these are relationship-centered and inclusiveness-centered, and that the regular academic training we mostly get isn't either of these. And we need to figure out a way to bring relationships and inclusiveness more to the center. And we also decided, I think, that this is a multi-level problem. We often think about these problems as problems of individual training. So one kind of example of that is that if you are interested in these things and you're an individual student, it's your job to go find all the places on your campus or wherever you are that offers this kind of training. Well, that's part of it, but it's also training that has to give the institutions have to learn how to have a new perspective on training. So we talked about the idea that there needs to be a notion of cross-disciplinarity, and we need to figure out, institutions need to figure out ways to measure and to assess that people have gotten to a certain level of cross-disciplinary insight. In addition to having institutions having a new perspective on things, communities need to have a new perspective on things so that community members can become full-fledged academic partners. And what does it mean for community-based organizations to think about themselves in a way that they are helping to create full-fledged academic partners in the implementation and quality improvement exercises. And we decided that two final things, that standard degrees are not necessarily proxies for this kind of knowledge. That, as Moira said in her first summary, that we need to develop a new kind of respect for spending time working on issues like these, and that that all these different constituencies need to know how to talk to one another across their major concerns, and that the support for these has to come not just from the individuals, but from the communities, institutions that support them.
Excellent. And any comments or thoughts on that one?
I had one. So just as, it's just a comment as you were talking, about like, does a degree like qualify? When I'm talking to especially junior investigators and they're looking at implementation frameworks and models and how do I apply this and what makes sense, I think my consistent advice over the last year has been, you need to have an understanding of kind of what models are out there in general, but you also have to go with your knowledge in the trenches of the context. What are the issues that are being faced, and how does that fit, like with the theoretical framework?
You're right, and I forgot one major summary we came up with, that this has to be largely experience-based. You got to go look, and you got to go be there.
Yeah. You're here.
Okay, and then was there a question?
No. Marcia's going to report out for our group, and I'm going to stand alongside and
all right,
moral
building
support
leadership
here.
capacity.
We are building leadership capacity.
All right, so our discussion started by first thinking about the challenges that folks are facing with leadership, and that ranged from having poor communication amongst leaders sometimes when you're trying to collaborate across different silos, to leadership. Is it representative of the communities that they're serving? Is there representation in the leaders? And also training. So within an entity that practitioners just get promoted to supervisors and managers, and they're not often trained to do that. So those were some of the things that came up. And so some of the things that we thought about as solutions that we've seen work are having a communication structure in place, especially when you're doing projects that have, let's say, Department of Health Services with mental health and a university. And what else do we have? There's something I'm forgetting here. Oh, that one of the other things is having shared goals, so that if within an agency, that there needs to be clarity around what is the goal that you're all working toward, and how is that communicated down to the trenches. And also when you're working with multiple sectors, that there's a shared vision, because each one of those is reporting to their own boards. And so how are you going to do that? The other thing that came up was, well, what about those entities that are really small and they don't have the resources to, for example, do research or use data and make improvement? And so we talked about partnerships. And one example that we talked about was Magnolia Community Initiatives, where Maura is partnering with them, and there's over 70 partner organizations. They all collect data, but UCLA and USC also helps with data. They report back in a dashboard, and they love it. So they don't have the resources to do it, but they certainly love participating and learning from the data. And so that was another solution, is this partnership. And the way that that works is having shared goals. So another thing we talked about was bringing leaders together. How do you engage leaders to come together? There was some discussion of having incentives, but the other discussion was, well, the intrinsic motivation of having these shared goals, shared targets that everybody can kind of get behind, and that drives them sometimes more than having financial or other sorts of incentives. And I think that's, am I missing anything? I think that's it.
Yeah, I think you got it. It's the, that vision of what that strategic initiative is, and then how leaders come together and how you align leaders towards that goal, and how they communicate both within their organizations and with collaborators, and solve issues of collaboration and individual needs and organizational needs in a large initiative. So great. Thanks.
Great. Well, any final thoughts or comments, both on leadership development or more generally on anything that sort of caught your attention today? Well, I think I'll turn it over back to Maura and Mike Gould to finish with some closing remarks then.
Okay, well, thank you, everybody. I realize now that to build on Hal Yu's metaphor from earlier in the day, I am the only thing standing between you and traffic. So I will try to keep my remarks brief. I told Brian that I'd go no more than 12 minutes, so you should be out of here long before 4 o'clock. My goal for this wrap up is to actually, my goal for the day was to try to learn at least one thing from each speaker. And my goal for this talk is to maybe remind you of one thing that you learned earlier in the day. So some of this is going to be redundant, and I'm going to try to put it in a little bit of a framework. And I don't know if any of you have read any of Paul Farmer's stuff, but he refers to this as the dismount. So, and I have a 12-year-old gymnast in my family, so in his honor, I'm going to do my version of the dismount now. This is what I learned today. It's a little bit complicated. It's a little bit busy. I was going to try to take you through it painful box by box, and I realized that was not viable. So I'm going to simplify it a little bit and start with this, very simplistic model of implementation science. And for those of you who have some experience or are not new to the field, you know that there are something like 68 different models and frameworks for implementation science. So the last thing we need is another model for implementation science, but I'm going to give you one anyway. And this is the SMIS, SMIS, Simplified Model of Implementation Science. And I built this literally as people were speaking today, so it's crude and it's simple, but I hope it's effective. And what I wanted to communicate here is that we've heard ideas from some really terrific speakers today, and at the beginning, it really starts with addressing a problem in health or healthcare, a real-world problem. And I think that's one of the distinguishing features of implementation science that sets us apart. It's not intrinsically better than doing very fundamental research in basic science, but it's one of our distinguishing characteristics. So we want to solve actual problems in the real world, and several speakers mention that. Personally, I think it is a big issue for our field coming to terms with this idea of prioritization, because there's no limit to the number of problems and the number of problems that we face and the number of opportunities that we have to improve. And if your settings are anything like mine, one of the most common strategies is that the squeaky wheel gets the grease. But there are some other factors that also come into play. So anything that's mandatory, by statute or requires public reporting, those are things that get a lot of resources. But that covers a very small part of healthcare and public health, and maybe very little of public health, in fact. And so for the rest of it, how do we set priorities, and how as researchers do we contribute to that conversation? I think it's really, really important and a very fertile area for those of you who are looking for dissertation topics or next projects. And once we've decided what we're going to fix or what we're going to work on, how then do we innovate, implement, and improve? We wouldn't be here today if it were easy. So by definition, we're kind of tackling the tough problems in public health and healthcare delivery, the things that where there's perfect alignment, the system's able to do it, the doctor knows about it and is on board with the intervention being effective, it's acceptable to patients. Those things kind of diffuse naturally. So when we're talking about implementation, we're talking about the tough problems, the ones that require active transport or some infusion of energy, some infusion of resources to make happen. And a lot of this I learned from Brian, who had to head off to the airport. But for me, there's this very nice distinction between diffusion, dissemination, implementation. Diffusion is letting it happen. Dissemination is pushing out ideas so that they can be taken up by others and then put into practice through an active process, or making it happen, which is implementation. So again, it's not easy, and there are several things that represent possible barriers, and all of this is beautifully captured in the Smiths. So is it a knowledge gap, a skill or resource gap, or a motivation gap? And this covers, I think, about 89.5% of the reasons why things aren't adopted in practice relatively efficiently, or on the other side of the coin, why inefficient or ineffective practices are adopted and then they persist in practice despite the fact that we know that they're suboptimal. So what kind of problem is it? Is it something we don't know about? Is it something that the system, the provider or the patient isn't able to do? Is it a capacity issue, or is it a motivation issue? They won't do it. So let's talk a little bit about what we've learned today that addresses each of these gaps. So what have we seen about the knowledge gap? Well, I think, Steve Dubinet started the day off nicely by talking about working together and breaking down silos and recognizing that we all have a unique perspective, and by sharing those, we can go further together. I think Tom Buchanan built on that theme in his brief remarks by talking about shifting the academic paradigm so that it's not just about creating knowledge. And there's a nice quote from Goethe that precedes all of the National Academy's report: "To know is not enough, we must do." Paradoxically, I often find myself flipping that formulation when we talk to clinicians and leaders in our healthcare system, because for them the imperative is to do. So we don't need to know, or we know enough already. Let's just go ahead and do it. We know this is the right thing to do. And one of my jobs as a researcher is to kind of put the brakes on that sometimes and say, wait a second, we need to do some diagnostics. We need to understand where the lesion is. We need to understand facilitators and barriers. Then we can go ahead and do it. So I kind of think that works in both ways. It's not enough to do, we must, or it's not enough to know, we must do, but in order to do, we must know. This idea of regional collaboration and making a transformation in all our healthcare systems by working together was really nicely illustrated by Hal Yi. And I'm just really, really impressed at what what Moira and others have accomplished today by bringing together this, really incredible group of people from, 12 or more different universities and healthcare systems from probably 100 different fields. This model of, coming together and talking about the challenges that we face and the approaches that we're taking is something that we should really build on. And I hope there are opportunities to keep this conversation alive so that it's not just a one-time-a-year thing, that we find ways to communicate more regularly. And that leads to the next thing, which is this idea of building trust and sharing data. And I think for me, one of the things that has really stood out in my 5+ years, 6 years now at Kaiser Permanente is that research and improvement are social and political processes. It's, the technical parts of this are challenging in their own ways. And I think Doug Bell could probably attest to that in terms of his work in informatics at UCLA, and others of you have similar technical challenges. But at the end of the day, if you really want to get things done, you need to engage very intensely in relationship building, in trust building, and there's really no substitute for having those relationships in place. We saw a couple of really nice presentations earlier in the day highlighting the advantages of leveraging technology or using technology-enabled approaches, and I think we're still kind of on the cusp of a world where a lot of public health and healthcare will be positively impacted by these kinds of technology-enabled approaches. So I thank both of those speakers for sharing their work with us. And then I'm going to skip most of what I had to say about the learning health system because I want to keep this brief. But I think for our purposes today, when you hear people talk about the learning health system, don't believe a word they have to say. Take it all with a grain of salt. I think it is largely aspirational. I think you talk to 10 people from Kaiser Permanente or any other health, Weill Cornell Medical Center in New York or University of Chicago. I'm just listing places where I know people who have an interest in this. I think we talk a good game, but I think we're really quite early in the path to being true learning health systems. And I think for me, the ideal is nothing less than learning from every single patient encounter. And it doesn't have to be, enrolling that patient into a randomized trial, but there is information in everything we do, and using our own data to figure out ways to take care of people better, and being able to do environmental scans so that we can take information from outside of our health systems and then apply it, requiring some process of adaptation to our own surroundings. I think those are really core essential features of the learning health system, and some of us are getting there, but there's a lot more work to be done. In terms of the skill gap or resource gap, like I said earlier, I don't think there's anything, and I don't think any of us are working in anything other than a resource poor environment or a resource constrained environment. There are always going to be constraints of this kind, and that's one of the reasons why I think that prioritization exercise that I talked about with the first slide is so important, because you do have to set priorities, and those resource constraints are ubiquitous. The other thing that we heard today is that, and I'll just reinforce something I said earlier, that both public health and healthcare delivery are, they're not things that happen in a vacuum. There are things that happen in a larger environmental context, and anything we do needs to, and you look at any implementation science framework, and they're going to emphasize factors that are operating in the internal context within your organization and other factors that are operating externally that in many cases are no less important, sometimes more important. So what can we do to overcome barriers in terms of skills and predominantly resources? You know, I'll just back up for a second to say, at first blush, you think about a knowledge gap and a skill gap, and one might be inclined to say, well, all you need to do is education. It's as simple as making sure people have the knowledge and the training that they need. But what I want to emphasize here is that those simplistic approaches are probably not enough. And in terms of capacity, it's not only about does someone have the training to do something, but do they have the resources to do that as well? And so if we want to leverage resources, we need to align our work with resources that are already available in the health system. We have some concrete examples of this from our work at Kaiser Permanente, where we have researchers who are embedded in existing organizational work groups. So these are things that the organization has already decided are high enough priority so that they're going to create teams of people. That costs money. And they're going to provide those teams with some resources to get things done. And we found that this is a really effective model for partnership, because we're not swimming against the current. We're on board with something that is already been prioritized. The other thing that I heard today that I think needs to be said more often is we need to get away from the idea of the one-off and building something for, you know, a given place and a given time, and without paying more attention to how are we going to scale this up and spread it to other settings. And not only that, but if it works in our own setting, how are we going to sustain it? And I had an interesting conversation with a nurse-trained quality manager at KP very early in my tenure there, who told me that for her portion of our quality improvement portfolio, there were no incentives built in. There were no nudges that were applied just for the purpose of the initial rollout, because she knew that those resources would go away when the project ended, and she wanted to design things that would live on after she was gone and after the program was over. And so I thought that was very, very thoughtful and worth sharing with you. And again, a couple of our speakers emphasized the importance of that. Engagement with leadership, engagement with partners in your health system or partners in the community, that's becoming increasingly obvious to all of us in this era of patient-centered and community-centered or participatory research, so I'm not going to say any more about that. We did touch briefly on the idea of leadership support in the session with Dr. Ahrens, and I think we could have a full-day symposium on how to work, how to do research operations partnerships that are win-wins and bidirectional in terms of the decision making. So something that's authentically collaborative, as opposed to a researcher going to a clinical or operational leader and saying, I want to do this project or I want to apply for this grant. So doing that in a more organic kind of way. And then finally, I just have a few thoughts about the motivation gap, and there's a whole field of behavioral science that's devoted to this, and I thought it was kind of curious that I couldn't find that many examples of things that we were talking about today. But of the three barriers here, knowledge, skill, motivation, I think this is the one that operates most frequently, at least in our health system. There's stuff that people just don't want to do. They don't believe the evidence, and I'm not sure how much you hear this in particularly in academic settings, but for the average Kaiser physician, they are much more receptive to research that's generated, even if it's bad quality research. If it comes from our practice settings, they believe it, as opposed to a rigorously designed, hyper-valid efficacy study that's in the New England Journal. They are really, really skeptical of stuff that's been done elsewhere. And the way I process that or think about that is that and I'm trained in clinical epidemiology and evidence-based medicine. So for much of my life, everything is validity. How do we assess threats to validity in this source of information? But my colleagues are completely on the other end of the spectrum. They're all about generalizability, and they're very quick to say, this won't work in my patients because X, Y, and Z. And sometimes I think they have a very good point, and it's obviously one of the major limitations of the traditional efficacy-oriented randomized trials, and it's why we need more effectiveness research and practice-based research. The other things that just come out of the implementation science literature are perceived advantages and the use of incentives and disincentives, financial and otherwise. I think these are tools that you should think about using in your work. And for me, I think there's a really interesting tension between doing single component interventions where you'd be able to isolate the effect of something on a behavior that you want to encourage or discourage on the one hand, and the idea that those things are not likely to be, so even though you can isolate the effect, it's less likely to be effective than a multi-component intervention that tries to align all of these forces to make sure that the knowledge gap is filled, make sure that people have the skills, capacity, and resources, and to overcome these motivational barriers. So that's kind of my 15-minute tour through implementation science as I've lived it for the last 5 years. And I just want to thank all of you for staying on till the end. Thank Moira and her team for putting together this wonderful event in this unbelievable setting, fantastic setting here in downtown LA. Our sponsors, our speakers, our presenters, and again, you for spending the day with us. So give yourself a round of applause. Moira, do you have any parting words?
Thanks so much. It was truly a team effort. I just want to extend a particular thanks to Ibrahima, Stephanie, Juan, and Angelina, and I think that's the crowd that's left. Lynette as well. Thank you so much for everything you did. We appreciate it. Okay. And hopefully see you next year, and hopefully some of the milestones that we laid out in our strategic sessions will be in place or going forward. So thank you again, everybody.